thank you everyone for joining. Avoidable harm and really performance clinically are big challenges that we at the Healthcare Alliance have come to believe can best be solved through collaboration across the country with health systems. To that end, we've brought a group of distinguished panelists from our founding member group, Bob Birnbaum from Partners Health and Dan Hyman from Children's Colorado and Julie Reister from UC Health. I want you to hear from each of them their unique perspectives about this. We'll dive in pretty quickly with Bob Birnbaum from Partners. He'll give us a little bit of overview of what their focus is at Partners on this and why they chose to come in as a founding member of the Alliance. Then I'll give you a quick overview about how it works and what we're actually doing together with a little more concrete look at that for 10, 15 minutes. And then we'll ask Dr. Hyman from Children's Colorado, followed by Julie Reister from UC Health to give you their views, their challenges, their perspective on what, why they are doing this as well. So again, thanks for your attendance, and Bob, let me hand it over to you.
Thank you, Bob. I appreciate it. And thank you for the opportunity of talking to your attendees today. If I could have the next slide.
Bob, there you go. Sorry, it took me a little bit of delay there.
No problem at all. So what I wanted to do was tee this up by giving people very quickly in a couple of minutes the flavor of our perspective from Partners Healthcare and why there is alignment between Partners Healthcare and our participation with the Healthcare Alliance. And I wanted to capture that by looking at this landscape for continuing professional development. And so it goes without saying that education is a knowledge industry in healthcare, and that there has been significant disruption because of the technology and the data analysis. And what we want to do is address these trends and pressures that are going on as a large integrated healthcare delivery system. And those are captured in those four verticals. The one on the left, that there are new care delivery models. We are a pioneering accountable care organization, and they're driving the need for more and more training of our entire workforce. The second is that we're really inundated with integrating with the adoption of new information technology tools, everything from clinical decision support to AI, artificial intelligence, VR, virtual reality, and the capabilities of adaptive and customized learning, as you'll hear more about from Bob Burgin. The velocity, and not just the velocity, but the veracity, the truth of evidence-based protocols is outstripping all of our antiquated learning methodologies that are not easily scalable, and resource allocation under a constrained economic environment is critically important to us for our sustainability. And then this increased accountability to oversight agencies very much speaks to the idea of a consortium of healthcare systems coming together and some of the capabilities that you'll hear about today, because they've created an unsustainable administrative burden that is contributing to workforce burnout and demoralization. So I put a quote in here from Graham McMahon, who is the CEO of the ACCME, with the old nomenclature about CME, and that although it has the capacity to really be a catalyst for change in healthcare, it is underappreciated. And underappreciated because people traditionally think of education and learning in health systems as being the sleepy little corner that takes place in like yearly update seminars, and they're not really yet acclimated to what the environment looks like today, where we're really a driving force that has a central seat with the other sectors in our healthcare system that deal with quality and safety and value. So if I could have the next slide. What I wanted to capture there.
I apologize, I am turning it, but it's just moving.
No problem.
There we go.
Yeah, no problem. Was really just the bullet points, which would be the segue back to Bob as the moderator, to say that we want to look at a concept which we capture by the term knowledge engineering, which is really a much more systems and holistic-based way of looking at the evolution from continuing medical education to continuing professional development. And if you take into account the data analytics as well as the administrative burden, the things that I've mentioned, you're really looking at the social, the technical, and the clinical aspects of knowledge management in our systems, or knowledge engineering. And so we have four basic principles. One is to adopt learning strategies that align with new healthcare models. We want to move away from perfunctory education that just carpet bombs everybody with the same information. And we want to link the learning to true process improvement and enhanced engagement. And more, that means that our assessments and our remediation needs to be pretty frictionless and more easily embedded into day-to-day workflows and activities of healthcare providers. And number three, we want to discern, and very much this will be discussed today, when targeted and individualized, and I would even add effective learning is warranted. And the last thing is to utilize validated education methodologies that employ demonstrable impact metrics. And so our mantra is that ultimately we want to determine how data will best inform standardized protocols, if at all possible, at the point of care. And that's really, hopefully, gives you a little bit of an overview of the environment that we're operating in. So I'll turn it back to you, Bob.
Bob, thank you for that. And I imagine there'll be some questions for you coming in through the question window here, and look forward to going through those. Let me just take a few minutes and show you the how of the what that Bob just described. He just beautifully articulated the dream and the problem. And together we've built this healthcare alliance with a set of tools, and I just want to show you what those are. We begin with this sort of high-level view of the problem, which I'll do in just a couple of slides. I think Bob did it much more beautifully than these in terms of specifics, but we believe that we now live in a healthcare performance economy. This is not a fee-for-service world anymore. It's a data-driven era of winners and losers. Where readmissions, variations in care, avoidable harm, and waste equal punitive reimbursement, which is very difficult on the health systems. Legitimate, aggressive incentive for change. Medicare will penalize about 2,600 hospitals this year. 250 to 400,000 patients will die, and 2.5 to 4 million will be severely injured due to medical error. I have to be careful with this medical error note. Brent James, who's one of the founders with us from Intermountain, has asked me to adjust that slide, and I forgot to do it, but it's through medical incidents. But this is a very big problem, and to some degree, hospitals have become a dangerous place as well as being heroic in the way that we save lives. And yet, with all this going on, we live in an information overload period. Bob alluded to some of the specifics of that a minute ago. And we also live in a world in healthcare where historically training's been fairly superficial. The sort of compliance-based training. And so when we put this together and started doing testing of technicians and nurses and doctors across the board, we found pretty consistently what we call confidently health misinformation at about a third of the critical information required to take on some of these clinical knowledge engineering initiatives. Not surprising, really, in the era of information overload and superficial training, but problem we really need to address together. So this is the initial founding group of health systems that joined us to figure this out, if you will, on the slide. And for about a year, we really didn't let anyone else in. It was this group of people rolling our sleeves up and trying to figure out how to move training. Those of you that I met at the CLO for Healthcare conference last week will relate to what Bob mentioned earlier. This is the group that came together and we said we have to move training from a sideline to a front row seat at the clinical table. One of the concerns we had was how well doctors would receive this. Inside of these systems, they received it well. So we decided that the very first wave of opening Alliance up would be all through hospitalist groups with all physician training to make sure that we had a large enough sampling of doctors across the country using the platform and giving us feedback, so we knew that the doctors would engage. If I can get this slide to turn. So we opened up to systems across the country and put a hospitalist steering committee together and began training doctors in systems across the country, and that's gone very well. If I can, I apologize for the delay on these slides. I'm controlling them remotely and having a bit of trouble. Wendy, why don't you take control of the slides back, and I'll just tell you where to turn them. I'm not successfully able to control it. I'm now 4 slides deep that I don't need to be. Can you back me up? Andy?
Yes, I will. Just 1 minute.
Thank you.
I'll...
Thank you very much.
Back to that. Let's see.
I want to go back to the Healthcare Alliance slide, 3 slides or so back.
All right. I think you have to give me back control to the mouse board, but I will. Nope, here we go. Tell me when.
Perfect. One more. So this is the Healthcare Alliance. We have about 60 clinical initiatives, from caudine eclampsia to safe injections to sepsis and others. And we begin with this notion of identifying and remediating what we call completely health misinformation. If you could go to the next slide. We defined together completely health misinformation as risk that's hidden in the neurons of the workforce. This is where people are sure but wrong about how to do something. Next slide. I want to jump right into the output from the learning system. You're all probably familiar with this Olympus endoscope with the CRA Superbug. If you'll go to the next slide. Across the top are the critical knowledge elements required to clean the scope to keep the CRA Superbug from killing the next person you put it, the scope into. And down the left is a large group of clinicians. Can you back up one? Everywhere you see a red box on this slide, that is a place where a single technician on a single element of how to clean the machine was confident and wrong, where they were sure they were doing it right but actually doing it wrong, creating risk to the patient and to themselves. If you go to the next slide. One of the things we do is then drill into this data, and you can click one more time if you would. We drill into this data and look at the misinformation at a granular level. This first slice shows you the best performing and worst performing hospital around technicians cleaning this. You know, it ranges from 18% to 50%. If you go to the next slide. It's more interesting. Let me see if that's going to draw. You may have to click one more time. It's more interesting when you then take the individual location and look at the variation of technicians standing side by side on at the same hospital. If technician 11 cleans your scope, you live. If technician 38 does, you're playing a little bit of Russian roulette. And yet the health system had no way to have this data. So they train the technicians, they certify them, they say, this person knows. And I want to point out this training came after a 2-hour hands-on training on how to clean the equipment one-on-one, and yet we still have this kind of variance. Next slide, please. This is, one more, please. This is the same concept, except here we're looking at the critical things you need to recognize sepsis as a physician. And so you see physicians down the left and critical information for recognizing sepsis across the top. And notice there's 46% or 45% completely health misinformation. Sepsis, as you know, is a killer and is very dangerous, and it's most dangerous if you miss it and send the patient home for the weekend. Next slide. You can click again. Notice how much scatter there is in the middle of this graph. It's very difficult to say, we want to go train all of our physicians or nurses on recognizing sepsis when you realize the amount of diversity of what's known and not known and where the confidential misinformation risk resides. Next question, next slide. So we begin with a highly targeted training. We in Healthcare Alliance don't live in the world of saying, we're going to take on sepsis, so we're going to build a 3-hour course that teaches you everything you ever want to know about sepsis. We go deep with the clinical teams and we say, what is the missing data that's causing people to die? And we build, in the entire sepsis module ends up taking about 35 minutes. So we build a highly targeted, interactive, online adaptive training module to teach, and it adjusts through adaptive software to each learner. So they move quickly through things they don't know. They go much deeper into things, they go much deeper into things they don't know. We provide this analytical report back to administration and learning to say, here's where the risk was. We then have a fairly sophisticated, we have about 1.2 billion now learner interactions in our software, and we have PhDs who sit and analyze that data all the time, and we've discovered a pretty thorough understanding of what we call regression or forgetting curves around specific types of information. And we're able to predict, based on the learning patterns, where a person is most likely to regress back. And so at a 4 to 8 week window, we push a little 6-minute refresher, can be to the phone or to the laptop. We push a little 6-minute refresher of just the information that's at high risk for regression. And they do that refresher, and if you test them 6 or 8 months later, that sticks. If you'll click one more time. The next part of the toolkit is what we call struggle analytics and systemic and environmental analytics. We don't just assume that because you got through a 40-minute module that you actually understood all of the learning in it. So the algorithmic learning system has an ability to sort of watch your learning pattern and predict where you tended to struggle and likely didn't understand. So if you'll click one more time, we'll go into this struggle analytics. This graph is like the heat map of misinformation, except here we're concerning ourselves with struggle patterns. So these are technicians down the left with the endoscope. Across the top are all the topics. Where you see the dark gray, we didn't teach the technician anything, they already knew it. Remember, this is after the training. You'll notice how much blue there is. The blue is where they didn't actually know it and we had to teach it. The vast majority, even after the hands-on training, they came in not knowing or having some doubt about their knowledge. But as you move into the yellows up through purples, these are learning patterns. I won't spend a lot of cycles on it here, but these are learning patterns of time and variance and repetition that we can study in an online platform at an individual level and produce a report back to administration. So if you'll click the next slide. What we do with the struggle analytics, other than produce the global heat maps, is we then sort that data. And this is all real data. Notice the almost non-existent struggle at the bottom hospitals and the 43% of the content struggle at one hospital. Then we drill into that one hospital and say, who are the humans there? Now you'll notice as an alliance, everything we do is anonymous. But as the hospital system, this data gets populated with real names. It's just that the central database doesn't look at real humans. It only looks at anonymized data. But we look at the individuals in that location and you'll see a huge variance of struggle to learn within those 3 technicians standing side by side. So if you go to the next slide, we then provide the local supervisor at that local hospital on that unit with an individual actionable analytics touchpoint report. Supervisor, take this one question to this one technician and spend a couple of minutes saying, look, you really struggled in learning with this. This is a critical piece of information. We should go through it real quick. I want to make sure you understand it. This is an empowerment tool for a local manager to not only know where people had misinformation or struggled, but also have a highly targeted touch point at their fingertips to go do something about it. This is what we mean when we talk about having a front row seat on the clinical team, helping drive clinical outcomes. Click the next slide. The last bit is that what we have found is that there will, for about 1% of the content we train, we will end up identifying a systemic or environmental problem. I'll just give you a concrete example. We trained 380 med-surg nurses across 17 hospitals, and one of them had this regression of 10x, which is represented in the graph on the bottom right there. One had this regression of 10x on one unit at one hospital, one operating room at one hospital. And so we went in with the supervisor and said, what's going on here? Turns out the equipment that we were saying was so critical that you had to use correctly didn't exist on that unit, that hadn't been ordered and delivered to that unit. So they weren't able to use the equipment at all. And this freed the team up to just tell us that. Based on these graphs and that showing up, we've now actually put a button right in the learning that lets the learner click and say, hey, I don't have that equipment, what's going on? So we don't have to do any guesswork to figure out where the systemic problems are. Next slide, please. So this is the Healthcare Alliance Toolkit. It begins with a highly targeted clinical engineering, knowledge engineering initiative. In other words, one of our members will raise their hand and say, I want to take on sepsis. And we'll put a team of experts together. We'll get down to the core stuff people need to know. We'll build the module, and then we'll roll it out and train across the various systems. And then we'll do this refresher. Then we'll study between the initial learning and the refresher where the struggle analytics indicate potential for a needed touch point. It tends to only be about 20% of the workforce and only about 12% of the workforce that needs some touch point. And it covers only about 25% of the content. So I don't want to act like the touch points are a huge operational initiative. They tend to be really small and really targeted. Next slide, please. You can go into the next slide. So that's the toolkit that the group has anchored around. And I'll come back at the end to talk to you about sort of what are the rules of engagement. Joining is free, but what are the rules of engagement of becoming a member? But let me pause and turn it over, if I could, Dan, to you to talk a little bit about your view on this and how you're using it.
Great. Thanks, Bob. Thanks for the opportunity to chat with you all. So I'm the Chief Medical and Patient Safety Officer at Children's Hospital Colorado. We are a almost 500-bed academic medical center outside Denver. We have about 7,000 hospital employees and about 1,500 hospital-based medical staff and another 1,000 community-based medical staff. And like every other hospital, have to think about how do we train our people. And one of the things that I've learned over the last couple of years as we've worked with knowledge factors has been this concept of confidently held misinformation, which is the person who is responsible for safety and for regulatory compliance scares me, as I know it would you. And so we've been starting to work with knowledge factors in developing modules for a couple of areas and are working on expanding those areas as we speak. The two things that we have implemented that I want to talk to you about are our what we call Target Zero training, as well as our safety coach training, which are modules that have been developed and in place for the better part of a year. And then we're expanding into other areas, including sepsis and cognitive bias and diagnostic error. But our main experience has been with our Target Zero training. So we are part of a hospital engagement network with over 100 children's hospitals around the country, all working on avoiding preventable harm and using a common curriculum that has been taught to all of the hospitals and that we train our employees on. We joined the network about 5 years ago, and for the first several years, all of the training was done in person to get all of our existing staff trained in a set of error prevention practices. And then we had to, once we completed that, think about what our go-forward strategy was going to be with all of the new employees and new medical staff that came on board. And so before we started working with knowledge factors and using the Amplifire module, we were again doing this as a fully live session on people's first days at work when they came in for orientation. And so we've had over 1,000 people now who have done the converted training that we have for error prevention using the module, and it's really been very well received. It's allowed us to standardize and improve this training, and we then reinforce it with something in person, but what we're doing is now able to test the timing of when we do the training, the computer-based training. Initially we did it in the beginning, then we did it 6 weeks later, and we're able to use the analytics that Bob just went through to try to tweak and figure out how are we asking these questions, when are we asking these questions, and so the analytic base is really helpful. Actually, go to the next slide, please. Sorry, I wasn't really paying attention to my slide. So you can see here, so we converted to new employee training last year, over 1,000 participants, and although Target Zero training is very specific to Children's Colorado and has language that we use, we also have a generic version of the module that's being finalized now that doesn't have Children's Colorado specific language because Target Zero is our kind of safety brand, but has the same error prevention training on stopping and thinking before acting and stopping to resolve uncertainty and using SBAR for communication and things like that. So that's been incredibly successful. The other module that we developed is one for our safety coaches. Now, not all of you may know or have safety coaches in your organization, but one piece of our overall patient safety program is to engage people in their everyday work who are passionate about safety, who we train to observe and give feedback just in the moment. So you're a nurse on the floor, you're a fellow in the cardiac ICU, you're a unit secretary, whatever, who has signed up to be a safety coach and get some training on how to give, it's really training on giving feedback. How and when you see somebody do something that's right, do you give positive feedback to reinforce the behavior? If you see or hear someone doing something not quite right, how and when do you give them constructive feedback? And we've developed a module in Amplifire that allows us to do that kind of training. And then actually I don't need to say too much about the data analytics. I think I have a slide with our specific, we go to the, so this is actually first what one of the questions looks like in our Amplifier module. This is a question about SBAR. It's too small to read the print, but there's a nurse calling and going through a clinical situation and not exactly using SBAR correctly, and then asking the learner, what else should Nancy have said? And it's the R part of SBAR that she hasn't said in that paragraph, and so the correct answer is, would you be able to enter the order in the next 10 minutes, which is my request as part of SBAR. So that's just an example of what one of the questions looks like in the error prevention training module. Next slide. And so here are our data analytics. You can see our confidently held misinformation scattered through. Again, the learners are on the left. The questions are going across the top. And you can see where people were when they started. It all gets to green at the end because in order to finish the module, you have to answer the questions correctly. But then the struggle chart shows me that most of these questions, most of the people didn't know the answer to, and I don't know what the percentage of struggle is in this particular representation, but there were a lot of people who who needed to learn it, and then more people who actually struggled, which also tells me that difficulty of the questions. They're not too easy, they're not too hard. You want to see, I want to see a mix of results here, and then knowing that the methodology and the software is going to get people to being able to answer the question. You can use follow-up testing in order to ensure that the knowledge sticks over time. So I think that's my last slide. Do I have one other? No. So I've just summarized by saying that we've been really happy with our experience with these two modules and with our partnership with Knowledge Factors in terms of developing the pediatric sepsis and some of the other modules that we're working on, and looking forward to spreading the use of this, because it is so much better of the user experience than our current annual training. And that, I would say, would be the long-term goal, to convert as much of our annual training over to doing it in this kind of a program, as opposed to the smaller targeted things that we're doing now. And I'll certainly be available to answer questions when we open it up at the end. And I guess I'm going to turn it over now to Julie, right, Bob?
Yeah, Dan, thanks so much for
Sure.
being here and for your thoughts. Next up, I'd throw it to Julie, who's the VP of Innovation at UC Health, to give us a few thoughts. Julie, are you there?
I sure am. Yeah, thanks very much, and thanks for allowing me to spend a little bit of time talking about our experience working with Bob and his team. As Bob mentioned, I'm the VP of Innovation here at University of Colorado Health, one of the large health systems within the state of Colorado. I actually am looking out my window right now at the Children's Hospital. I'm very fortunate that my office is located at the Anschutz campus, where our large academic medical center within the system is located. So while UC Health, as Bob had talked about, was one of the original members in the Healthcare Alliance, I would say that our efforts to really ramp up activity and operationalize and implement a plan with the Amplifire team have just occurred in the last probably 5 or 6 months, really, just since I got here. So I just want to share a little bit of how we've been approaching this, and just my delight in being able to work with Bob and his team. We actually had a little bit of fun with Bob's team this past week, in that we had a joint board meeting for UC Health, which gathers all of our senior executives across the system in one site for an annual meeting. And so there was a feature of innovation, which we were really happy to present to the team. And one component of that was that Bob's team helped us to put together a little innovation trivia quiz within the Amplifier module that we sent out to our senior team. They were a little bit tricky, and yes, it was trivia, certainly not the important things that we're trying to target. But we thought it was really important to be able to help in a more tangible way the leaders within our system to really understand how we aim to transform some of this perfunctory education that all of us have been subject to, whether it's been throughout our career in healthcare as a recipient of it, or really trying to lead teams and to improve clinical outcomes. So it was a bit of fun to see that they, in fact, did end up with about 30% confidently held misinformation. If you look at the next slide, we were able to take that same group. We only got about 10 of them to complete this, and there was certainly a much larger group. But again, it was still fun to be able to walk them through some of the core concepts that were discussed earlier. So if you go into the next slide, I'll just highlight a bit of, again, my experience in the last 6 months. Currently, I've been working very closely with Bob and his team, and we're really managing some of our early work through the UC Health Innovation Center. We had an opportunity to deploy the hospital-acquired pressure injury staging module early on, and we are really in the point right now of just analyzing some of the heat maps that Bob talked about in terms of being able to see where our team fell in that area. But one of the things that I'd like to highlight is that we have also had an opportunity to co-develop a pressure injury prevention module. And this has really been exciting from all of the contributors here at UC Health. We've been able to assemble a team of subject matter experts throughout the nursing division to work closely with Bob's team to put together what feels like to me a module that's been done in really record time. It's been literally 8 weeks since we kicked off the initial meeting and started to provide the rich evidence that would need to be put together for Bob's team to help develop the modules. And as of this week, we've already done a soft launch to ensure that some of the individuals, such as the educators, the skin champions, will have a preview, so to speak, of what will be rolling out mid-July to close to 1,200 nurses. So we're very excited to have something that we know is such a challenge across really all of healthcare, and to have that module be really the first one that we've been able to not only co-develop, but really we'll see throughout fruition. So additional efforts that are underway right now are really mapping the existing modules that are in the healthcare library that the Alliance members have put together, and really looking at what our current education efforts are around that. And then using another tool that Bob and his team had provided, where some of the leaders within the organization are going, so to speak, through an ROI exercise to evaluate what are we doing right now, and if we move over to utilizing the Amplifire modules, what goes away. And it's really some of the early work that those teams have done. It's illuminating some of the many efforts that maybe weren't as targeted as they should have been, and will allow us to be much more standardized in our approach, and I think a lot more efficient with our time and our dollars, and hopefully with some better outcomes. So our plan will be that really the full implementation and approach that Bob so beautifully articulated from partners is very similar to how we look at this here at UC Health. And we've got a system-wide team that we're assembling that will really start tackling this on a much broader sense. And then we'll continue to manage and hopefully grow the library of content through some co-develop opportunities that will be managed through the Innovation Center. So that's really our story at UC Health. Again, it's been just a lot of fun and a real exciting opportunity, I think, to see the unique ways that we can really, I think, drive to better outcomes and really transform how education is occurring. So I'll turn it back over to you, Bob.
Julie, thanks so much, and what a focused effort you've had at driving this along, and it's just great fun to work with you. So let me just take a minute before we open up to questions through the app, if there are some. We've talked a lot about this alliance. What does it mean? There's no charge to join the alliance. Membership is free. The courses, there is expense. The expense is that you buy the courses. You're buying them from each other. So the courses are all developed, as Julie just beautifully articulated. A team of people at a facility comes together, builds a course, and then effectively puts that into the rest of the members' library to download and use. And so when that happens, we want to compensate the team that took the time to build it. And so there's a 30% rev share back to the member that built the course every time somebody else uses it, so that it becomes profitable to build out the course library as a group. The other meaningful reality of joining is that all of our members agree that all of the data from every learner, and you can tell from the analytics we track everything imaginable, all of that data gets blinded and scrubbed and goes into a national database to the benefit of all the members. So you agree by joining and using the training that your completely blinded and anonymized data becomes part of the asset that we all use to benchmark ourselves and try to figure out where our problem areas are and so forth. So we all get smarter together as we go along. Generally, in terms of how the process works, if you're interested, what we generally do is we set up a meeting with the Chief Quality and Safety Officer, Chief Nursing Officer, Chief Learning Officer, and maybe a Chief Medical Officer. I know that's not a casual thing to say, get those people in a room, but if you're truly interested in joining, the most efficient way to move through this is that we set up a meeting with those people. We fly out, we take 1 hour, and we show them exactly how this works. It's much more detailed than what we showed you as an overview today. We go through the courses that are available. We talk about pain points inside your system where you may want to focus. We talk about areas where you may have some expertise where you're going to build courses, and then we put a plan together to launch. Often people will go straight into using the platform because of the success of others, but it's also really common that people say, I want to do a pilot of 300 people through a course just to make sure my users respond well. That there's no cost to do that. We're happy to do free pilots to show it. At the end of every course, there's a full readout where we bring in all the analytics and the actual language touch points and all that. And we show up initially in person, and eventually we can do them through web conferences, so that you make sure you're getting the full operational value out of each round of training. Just big picture, the courses, a knowledge engineering clinical initiative at scale will be, depending on how much scale you have, somewhere between $20 and $30 per employee. So if you decide to take on sepsis, the cost is going to be $20, $25 or so per employee that you need to train for the full impact and analytics. Everything's included in that. There's no other cost. So that's kind of the ballpark of how this works. What we'll do is have Katie Abbott pictured here, who is the person who would show up with me and put the plan, if you're interested in joining in place, and work with your team to show them what we do. She will reach out to you in the next 24 hours following this conference with a copy of this deck and just a question of whether you want to proceed to a discussion in person. And if you do, she'll help orchestrate that. And then I'll show up whenever you say, and we'll get it moving. Any questions or anything that we need to cover, Wendy?
Yes, we have a couple here. The first one is, I think, to the panel in general. How has your staff received and responded to this new way of learning?
Dan or Bob or Julie?
Well, I can start. I mean, the people who have done it were by and large not exposed to, a prior way of doing it. But what I would say is that the receptivity to this as a way of doing it has been quite positive. We've had people who have, in addition to the Target Zero training and safety coach training, had people, for example, who have been testing the sepsis module. And so with each of them, we've had the opportunity both to get constructive feedback as we develop the courses and have tweaked them as we've done them, as well as, gotten, really quite positive feedback. I can't think of any significantly negative response that we've heard from our staff that have used the Amplifire module.
Let me just throw one additional comment to that. This is Bob again. The one thing we learned, and it's part of why we held this alliance close to the vest and didn't bring in 20 members right out of the gate, is we needed to figure it out so that we removed all the friction and pain points. One of the things we discovered early on is that it's really common that if right now, for example, Providence is about to buy a large-scale rollout of a CDIP course that Bob Birnbaum, who's on the phone, is developing at Partners. Inevitably, what happens is people love the core knowledge that's built into it, but they want to adjust it a little bit to match their exact protocols or their, every time you buy a course from Partners and roll it at Providence, the learners, the employees only see the Providence brand. The Partners brand just appears in the catalog, to the quality and safety officer or the learning officer who's saying, I want to roll that out, who built it. But once it rolls out, it's only your own brand that's on it. But within the course, there'll inevitably be 2 or 3 questions that the system will want to customize to their environment. And we weren't originally set up to do that, but now that's really seamless. Bob or Julie, any other comments on that question?
Yeah, I guess the only thing.
No, go ahead, Julie.
Okay, just a quick comment in terms of another group that I think appear to be pretty delighted about this approach, and that really is the educators and the frontline clinical managers. Probably no surprise to those of you that are listening in on the call. They really just feel like this is an entirely new set of tools that now affords them an opportunity to really interact with the individuals that have taken the exams, to really help them understand where their struggle is or where their learning is. So certainly from the individuals that have taken the test, we've had similar response. They enjoy it, they find it interactive. It's much better than kind of the rote education, but I think those other 2 groups are also very excited about the tool.
Yeah, I was going to say something along to dovetail with what you just said. And as Bob Burgin knows, this is Bob Birnbaum at Partners. My basic science research background is in neuroscience, how the brain learns, how it encodes, and how it retrieves information. And one of the things that maybe has not come across quite as clearly as it could in the presentation is that we're not inundating people with information and then testing them on it. We're actually doing it the reverse. And the algorithm here is very much based on some basic principles of cognitive psychology and neuroscience to get people engaged and activated so that when they're exposed to the information, in other words, they answer a question, they're told that it's wrong, they're not frustrated or delayed, but they aren't told the answer immediately. They're put into a more engaged and activated state so that it almost has a gamification quality to it, so that they're then given a micro-learning moment in which they're given a digestible amount of information that they'll actually retain. And so this was something that was of real interest to me because of my background, and watching users have this emotional response to saying, well, wait a second, I thought it was this, and then go to the next question, which is so different than PowerPointing somebody to death with just an avalanche of information and then perfunctorily just questioning them on it, whether they got it right or wrong.
Yeah, Bob, I really appreciate you bringing up the brain science. I neglected to say that the underlying learning platform was built in partnership with the Brain Science Center at Harvard University and the Center for Learning and Forgetting at UCLA, and 4 other brain science research university-based groups, including Roddy Rodiger, who's hooking people up to fMRI helmets and watching different techniques of training and learning, who authored the best-selling book Make It Stick. All those folks sit on what we call our science advisory board and helped us build this algorithm. And we just don't have time to cover all of that in this kind of setting, but this is probably the most advanced brain science learning algorithmic tool in the market today, and we're really, really pleased to be rolling it out in healthcare. Were there other questions?
Yes, indeed. What, if anything, did you have to get rid of in order to make room for this solution?
Oh, that's a good question.
I just don't feel comfortable naming the name of different companies that we've jettisoned out of the healthcare system to make room for it, but go ahead.
You're right. Right. If you think about, we took a very elongated, complex classroom-based training and condensed it down to about 45 minutes of exactly what you need to know when you're the only learner and the system's just dealing with you. The biggest initial trade-off is taking the clinician off the floor less and doing this in a much more efficient way. But certainly people are starting to put down some components of other software. And you know, I guess I'll agree with you, Bob. It probably makes sense not to be naming because there's been a pretty consistent thread of changing out software. I think you're right. That's not the right setting. Maybe in our face-to-face meeting, we'll go into that more detail. Anybody else have comments on that one?
Well, also, the online isn't the be-all and end-all of it. I mean, what Bob has alluded to is sort of strategic allocation of your resources when you need to do something on a kind of touch and feel basis. And so there is a scaling issue. We're trying to wrap our arms around understanding what's scalable and not. And so not that it's an easy lift, but we're able to look at affording more time to providers because they're not sitting in endless, repetitive live sessions that are long, and they're doing things when they need to. They may have to do that for certain technical skills, but otherwise there's lots of things that can fit into this, and as Bob said, create real economies of scale and efficiencies.
And I think Julie alluded earlier to when looking at our library, trying to decide which courses to focus on. One of the things that is very common that she discovered was, you know, oh my gosh, I didn't realize this is not UT Health or Julie, but I heard this in another founding partners. I didn't realize we had 47 different initiatives for sepsis going on, and none of them were working, and nobody knew about all of them. And people are going up and saying, I'm killing people because of sepsis at a local or regional level, and they're just spending dollars trying to solve that problem. And so one of the things you do is you gather up all the initiatives that are going on and you say which ones are working and which ones aren't, and let's stop spending money on the ones that aren't and supplement it with this highly targeted global approach. Mm-hmm. We see that a lot.
Thank you for answering that.
I know we're nearing the end. Was that the last question?
We have 2 minutes, and we have one more question. How does this solution relate to or tie into clinical decision support and the electronic health record?
Bob, I think I'd probably throw that one your way. More than
yeah, I'll very briefly say, for time's sake, there's actually, I run a healthcare knowledge transformation lab at Partners, and downstream what we're looking at is exactly the CDS integration into EMR. One of the things that everybody knows is an issue with that right now is alarm fatigue, and also the credibility, our override rate of best practice alerts, and this is not unique, this is true across the board, is upwards of 80–90+% override. So developing a dialogue between the provider and the EMR, especially one that gives them a path of least resistance and reduces their number of clicks, is really important. What we haven't had time to get into, and it's sort of blazing the trail, is looking at the analytics that this is doing as to where information is misinformation or missing information. Really does help inform how you're going to look at your integration of CDS into EMR. So it's an excellent question.
Yeah, I think Bob, you're probably as advanced as anyone we've seen in leading the thinking on that. So I'm really excited to see where that goes in the next year. Okay, I think at the end, first just a quick thanks to Julie and Dan and Bob, mostly for everything you're doing for this cooperative effort in the Alliance, but also, of course, for taking time today. And for those of you listening in, look for an email from Katie Abbott tomorrow, and if you want to continue the discussion, you can set that up directly through her, and love to talk to you more. Thanks, everyone, for attending.